Our lecture today is about prolonged pregnancy. Now, the average duration of pregnancy is 280 days, which equal to 40 weeks pregnancy. And according to that, we have two definitions of prolonged pregnancy. The first definition is post-date pregnancy. What we mean by post-date pregnancy, pregnancy which pass after 40 weeks gestation or after 280 days. While post-term pregnancy mean pregnancy which pass beyond 42-week gestation or beyond 294 days. The incidence of post-term pregnancy is about 5 to 10%, and it is more common in primi gravida. Now, what are the causes of post-date pregnancy? The exact cause is unknown, but the majority of cases the cause is due to wrong calculation or error in dating. The patient may don't or may didn't remember her last menstrual period. The third cause is it is in primiparity and previous prolonged pregnancy. If the fetus presented with an encephaly, fetal adrenal hypoplasia, and placental sulfatase deficiency. Also, it is more common in obese mother, in white race, and if the gender of the baby is male. And lastly, there is genetic predisposition for post-term pregnancy. So all these regarded as etiological factor, but the true cause is unknown. Now, what are the physiological changes which occur in post-term pregnancy? We can divide it into placental changes, amniotic fluid changes, and fetal changes. With regard to placental changes, there will be atherosis of the vessels, aging, and infarction and calcification of the placenta. The amniotic fluid changes can be divided into qualitative and quantitative. The quantitative changes, there will be decrease in the amount of liquor or oligohydramnios. This is due to diminished fetal urination. While the qualitative changes, the color of the liquor become cloudy due to presence of flakes of vernix, and sometimes it become greenish due to presence of meconium. The LS ratio is more than 4:1. The fetal changes, in post-term pregnancy, in majority of cases, it become macrosomic baby. 45% they have macrosomia, mean increased weight of the baby more than 4.5 kilogram. On the other hand, 10% will have IUGR due to placental calcification and atherosis of the vessel. The rest are normal. Now, the complication of post-date pregnancy can be divided into maternal and fetal complication. The maternal complication include anxiety, of course, because the pregnant woman and her family will be anxious about the fate of pregnancy. There will be traumatic vaginal delivery and sometimes shoulder dystocia due to big size or macrosomic baby. Increased incidence of cesarean section, again due to oligohydramnios and increase in the weight of the baby. And finally, there will be a risk of postpartum hemorrhage, mainly due to trauma. Regarding fetal complication, there will be increase in the incidence of fetal distress, meconium aspiration syndrome, fetal trauma because difficult labor and large baby, brachial plexus injuries and clavicle fracture. This especially occur if the delivery complicated by shoulder dystocia, which need special maneuver to deliver the baby. Number 5, increased perinatal mortality. And finally, number 6, post-maturity syndrome. And what we mean by post-maturity syndrome, it is a complication of post-date pregnancy. Occur in 25% of cases of post-term pregnancy. There will be meconium-stained liquor, oligohydramnios, fetal distress, evidence of loss of subcutaneous fat of the baby, and finally there will be dry, cracked skin. So all these are signs of post-maturity syndrome. The prevention of post-date pregnancy, either by induction of labor if the cervix is favorable at term, or by sweeping of the membrane. This is done by digital examination, and we will try to separate the cervix from the membrane. This will release prostaglandin and enhance ripening of the cervix and contraction of the uterus. Number 3, vaginal intercourse also acts as the same mechanism as sweeping by increasing the release of prostaglandin, and finally acupuncture. The management of post-term pregnancy depends on several points. These points include the following. Number 1, we have to confirm the gestational age. We should assess the gestational age accurately. Number 2, we have to look for the presence of any risk factor in the mother which not allow the patient to go to post-date pregnancy. Number 3, we should do fetal surveillance to detect evidence of fetal distress. Number 4, we should do pelvic examination or PV examination to assess the Bishop score and assess favorability of the cervix for induction of labor or for termination of pregnancy. And number 5, maternal preference, what the woman want or what the pregnant woman want. Did she want to terminate pregnancy or to continue and wait till normal delivery? So we should have complete counseling with the pregnant woman and involve her in the final decision of termination of pregnancy. Now we come to each point separately. Number 1, how we confirm gestational age. So confirmation of gestational age, also we have to depend on several points. Number 1, we should have reliable last menstrual period. Reliable last menstrual period. What we mean by reliable last menstrual period, that the date should be known, exact date should be known. She should have regular cycle. There should be no history of oral contraceptive pills for the last 3 months and no history of lactation. So all these conditions should be present to depend on last menstrual period for assessment of gestational age. Number 2, in the gestational age, we can depend on first trimester ultrasound, which measure the crown rhomb length. Number 3, we can depend on second trimester ultrasound, which detect or which measure the biparietal diameter. And preferably here, we have 2 ultrasound in the second trimester to depend on. Number 4, pregnancy test. And pregnancy test, we have either serum or urinary pregnancy test. For serum pregnancy test, we say that the pregnant woman at time of pregnancy test, at time of serum pregnancy test, she is 5 weeks pregnant, roughly. And at time of urinary pregnancy test, she is 6 weeks pregnant, roughly. And then calculate the rest period accordingly. Also, we can depend on quickening, which occur at 18 to 20 weeks in primigravida and 16 to 18 weeks in multigravida. Again, this is rough estimation. We depend on if all other measures to detect gestational age are not found. So this is confirmation of gestational age. Number 2, as we said, we should look for the presence of maternal risk factor which prevent the patient from go to post-date pregnancy, or we should not allow the patient to go to post-date pregnancy. What are these risk factors? These include pregnancy-induced hypertension and preeclampsia, Rh incompatibility or Rh negative mother, pregnancy with jaundice, previous lower segment cesarean section, transverse lie or abnormal lie, contracted pelvis, breechless baby, intrauterine growth restriction, premature rupture of membrane, previous history of intrauterine death, bad obstetric history, history of antepartum hemorrhage, and of course diabetes and infertility, which is not written here. So if any of these risk factors present, we should not allow the patient to go to post-date pregnancy, and we should terminate pregnancy immediately. Number 3 in the point which depend for management of post-date pregnancy is test for fetal surveillance or assessment of fetal well-being. And there are three major methods for assessment of fetal well-being: either fetal kick count, non-stress test, and biophysical profile. So if there is evidence of fetal distress, we can terminate pregnancy at the same time. And as you know, fetal kick count, there should be 10 count per 12 hour from 8 morning, like example, to 8 evening. Non-stress test, there should be 2 acceleration in the fetal heart rate with uterine contraction. And biophysical profile depend on score. It is score depend on 5 parameter. Number 4 in the point which depend on to manage post-date pregnancy is PV examination to assess Bishop score. And as you know, Bishop score consists of 5 parameters mainly related to the cervix and station of presenting part, the position of the cervix, consistency, effacement, dilatation, and station of presenting part. And the total score is 10. If Bishop score is more than 6, it means favorable cervix for induction of labor. So any patient with post-term pregnancy and have pelvic examination which reveal favorable cervix, we have to do induction of labor. Number 5, maternal preference. What the patient decision after counseling? Did she want to continue pregnancy and wait until spontaneous labor occur, or she want to have induction or to undergo induction of labor? So in summary, the management of post-date pregnancy from 40 to 41 week gestation. If patient presented at this gestational age, first of all, we should look for any risk factor, as we said, risk factor like hypertension, diabetes, previous cesarean section, antepartum hemorrhage, and so on, or there is evidence of fetal distress. We have to do PV examination. And according to PV examination, if the cervix is favorable, we do induction of labor. But if the cervix is not favorable, we do cesarean section. So presence of risk factor, favorable cervix, induction of labor, unfavorable cervix, cesarean section. On the other hand, if there is no risk factor, there is normal uncomplicated pregnancy and normal fetal well-being or normal fetal growth. Again, we do PV examination. If the cervix is favorable, we do induction of labor even if there is no risk factor. But if the cervix is unfavorable and it is normal pregnancy and normal fetal well-being, we have to do expectant management. And by expectant management, we keep the patient on kick count daily, and we do for her non-stress test, biophysical profile once per week. If these tests are abnormal, we do induction of labor. Otherwise, if normal, we can continue pregnancy. If continue pregnancy, or if the patient presented from 41 to 42 week gestation, of course it is healthy, uncomplicated pregnancy. So we discuss with the patient the option of risk of expectant management versus induction of labor. We told her, or we tell her, that expectant management depend on several tests, and induction of labor carry such benefit and such risk, and we have to convince her that induction of labor is better for her to avoid complication of macrosomic baby and oligohydramnios. So we try to convince her about induction of labor. But if the patient refuses induction of labor, also again we have to do expectant management. And the expectant management now, including daily kick count, plus non-stress test and biophysical profile twice per week. If these tests are abnormal, we do induction of labor immediately. But if normal, we can continue until 42-week gestation. At 42-week gestation, we have to do induction of labor even if the tests are normal and everything is normal. We have to do induction of labor and terminate pregnancy. Regarding intrapartum management, the patient should be kept in left lateral position. There should be continuous CTG for monitoring fetal heart. There should be yearly artificial rupture of membrane to see the presence of meconium. Lower segment cesarean section if CPD or evidence of macrosomia. Amnion infusion, and here we instillate 750 cc to 1000 cc of normal saline or ringer lactate inside the amniotic cavity to decrease meconium and to correct variable deceleration. And finally, there should be pediatrician present at the time of delivery, especially in the presence of meconium. Thank you.